Welcome, everyone. Today's topic I'm really excited about is redesigning cardiovascular healthcare delivery and integrating diversity and health equity to improve outcomes and address health disparities. As you all know, the pandemic exposed the disproportionate health effects of discriminatory policies and disparities in employment, housing, education, and healthcare access, where racial and ethnic minorities had the highest mortality rates during the pandemic. It also highlighted, I think, how social determinants of health can so profoundly influence health and the urgent need to better operationalize structural social determinants of health components within both clinical and policy interventions to reduce those health disparities and improve overall health in general and cardiovascular health in particular. Cardiometabolic diseases are an increasing cause of morbidity and all-cause mortality in the United States and around the world for that matter, because of the increasing prevalence of those diseases that affect cardiometabolic health, such as diabetes and obesity, but also because of the massive disparities in care and the gap in the social determinants of health that I just mentioned. However, I think the pandemic also provided some hope that with grassroots organization and careful planning, resources, and technology deployment, as well as human effort, if that can be focused where it makes the greatest difference, we can have an impact. And so given some of the encouraging signs that we saw, as one of the articles our guest speaker provided stated, if we act now, we can significantly reduce the impact from the impending tsunami of common chronic diseases. And it's hard to imagine a better speaker to opine on the threat as well as the opportunities in this area than our special guest speaker today, Dr. Jennifer Mieres. Dr. Mieres is a professor of cardiology and the Associate Dean of Faculty Affairs at the Zucker School of Medicine at Hofstra Northwell. She's the Senior Vice President of Northwell's Health's Center for Equity of Care, and she provides strategic guidance for Northwell's diversity and health equity initiatives, as well as serving as the health system's first Chief Diversity and Inclusion Officer. Thank you so much for being here tonight with us. We're really looking forward to your presentation.
Thank you, Dr. Dodig, for the kind introduction, and truly good evening, and truly honored to have the opportunity to speak to everyone about this important topic and share sort of ideas on how we can redesign cardiovascular care or redesign all of healthcare to truly integrate the components of diversity, inclusion, health equity. And hopefully at the end of this presentation, you will be convinced that redesign is inevitable and definitely possible, and that we all have a part to play. So these are my disclosures. And what I'd like to do at the end of our 45 to 50 minutes or so, really at the end of this presentation, hopefully you will understand the connection between determinants of health and adherence to a medical treatment plan, the urgent need for redesign, as Dr. Dodig highlighted, why we need to integrate the components of cultural awareness, health literacy, preferred language into our treatment plan for the patient with cardiovascular disease. And then I will share with you a little bit of the framework that we have adopted that's evolving at Northwell Health to change healthcare delivery. We will explore this topic by way of two patient stories, and then sharing with you the framework and some of the scientific evolving evidence to support the integration of the components of health equity into a healthcare delivery model. So what is the evidence to support this expanded model of healthcare delivery? And I'll take you back to the turn of the 21st century, or the start of the 21st century, when the Institute of Medicine, which is now the Academy of Medicine, published the landmark document, Crossing the Quality Chasm. And this was published in 2001, and it provided a roadmap for us in the healthcare community to expand our healthcare delivery model from the acute care methodology to one that is focused on prevention. And the roadmap provides 6 pillars for us to adopt. One, that healthcare should be efficient. It should be effective, that we should use scientific knowledge to all who can benefit. We should avoid waste. It should also be safe, and that is the whole quality movement, avoiding injuries to patients. It should be timely, reduce waits and delays for those receiving and providing care. And two additional pillars and important pillars, that healthcare for the 21st century, which deals with the epidemic of chronic diseases, should provide care that is patient-centered, and that is care that is respectful and responsive to the individual patient's needs. And also, I still call this the forgotten aim, it should be equitable. Because over the past decade or two, we have recognized that there is definitely healthcare disparities based on race and ethnicity and social determinants of health. And the Institute of Medicine followed that publication in 2003 with another landmark publication called Unequal Treatment, where they summarize all of the evidence to show race-based healthcare delivery disparities. What is the impact of chronic diseases, and why is this a national health concern? I think it's fair to say that our advances in technology and medication and treatment strategies and different guideline-mediated algorithms have really led us to the point where diseases that were once fatal are now chronic diseases. And you look at the impact of chronic diseases for the 21st century, and you see that 6 in 10 adults in the United States have a chronic disease. 4 out of 10 have 2 or more. And what are these chronic diseases? They include heart disease, which was initially fatal. And you go back to several decades, when someone had a heart attack, it was definitely fatal. And the average lifespan was in the 40s. We went up to the 50s. But with the advent of stents and statins and great pharmaceutical interventions and diagnostic algorithms and ICDs and pacemakers, heart disease has now become a chronic disease. Yet a lot of our methodology and our treatment strategies are based on the acute care situation. Cancer, many forms of cancer are now a chronic disease. COPD, stroke, Alzheimer's disease, where a lot of research is going on, diabetes and chronic kidney disease, all chronic diseases. Why is this important that we expand our healthcare delivery model? Well, we look at the cost and the business imperative that 90% of our nation's $4.1 trillion in annual healthcare costs are for people with chronic disease and mental health conditions. This is indeed a looming burden, and the urgency for us to expand our healthcare delivery model. And you can see here, these are older data, but still applicable today from the Harvard School of Public Health, highlighting the fact that the projected costs for chronic diseases such as cardiovascular disease, cancer, mental health disease, diabetes, and this is before COVID, would be, if left unchecked, or healthcare delivery model would be in the trillions. And you see here cardiovascular disease at 15.6 trillion if left unchecked. You think of the everyday experience, and you see that 60% of us have 2 or more chronic diseases, 90% of our healthcare annual expenditure, and how it impacts our patients. 35% of people in the United States are struggling to pay healthcare bills. So let us take a look at what constitutes chronic diseases, what is the effect of chronic diseases, and what we can do as we redesign healthcare to truly empower our patients and change our healthcare delivery model to improve outcomes. You see this infographic from the CDC that highlights, again, the statistics I shared with you: 6 in 10, 1 chronic disease; 4 in 10, 2 chronic diseases. You see what all the diseases are there. And so when you look at the bottom of this slide, you see that the key lifestyle risks for chronic diseases, that as we treat chronic diseases, yes, we give medications, we make a diagnosis, but outside of the medical encounter, it involves lifestyle changes like physical exercise, quitting smoking, food and nutrition, and making healthy choices. These factors are important because when we look at what goes into one's health, we see that healthcare and the interaction in healthcare only accounts for 20% of health outcomes. So as we shift our focus onto outcomes beyond the medical encounter, 80% of health outcomes depend on health behaviors, physical environment, as well as socioeconomic factors and the so-called social determinants of health. And we'll talk more about those coming up soon. So clearly, as we understand what goes into health and we redesign healthcare, incorporating the factors of social determinants of health and other factors must go into the treatment plan. So let us take a look at a case that a 49-year-old woman that we had the pleasure of meeting, and we met NR when we were producing our last documentary called Misdiagnosed that colleagues, Dr. Stacey Rosen and other colleagues and I decided to do. Laurie Russo working with Emmy Award film producer Trish Reagan, who produced Autism the Musical. We felt we needed to share stories of why there was an urgent call for sex and gender differences, and a plan to really integrate women's health into everything we do with a much more broader approach. And so we produced Misdiagnosed. It came out just as COVID struck. It premiered at Cinequest. But in Misdiagnosed, women share their stories of being misdiagnosed. And here is a classic example. So NR, 49-year-old Afro-Latina woman, originally from the Dominican Republic, mother of 2 teenagers, works as a home health aide, 14-hour-a-day job. And she presented for evaluation of 6 months of typical chest pain, which goes along with what the textbooks say heart disease should be like, right? Ischemic heart disease. The pain was classic, located in the mid-chest, came on with emotional stress, and relieved with relaxation. Now here is a classic example, and Dr. Nisa Goldberg, who is part of the Atria family, will tell you, and she's written about this, that women are underdiagnosed. And this was a classic example where NR went to the emergency rooms on 3 prior ER visits and was diagnosed and sent away with indigestion and told that she was too young to have heart disease. So she comes back, and this is the 4th episode, and we'll get to what we did on the 4th episode, what she shared. And you look at her medical history and you see she's had gestational diabetes and preeclampsia during her last pregnancy. We now know that pregnancy-related complications are stress tests and have a worse and predict impending cardiovascular disease 5 to 15 years later. Her family history was really strong for heart disease. Older brother had CAD with a stent to the left anterior descending at age 52. And you look at her baseline labs, and clearly she's diabetic with a hemoglobin A1C of 8.4 and an LDL cholesterol of 140. So on her 4th ER visit, she was referred, she came in, her pain resolved because it was just a short period. She ruled out for an acute myocardial infarction or acute coronary syndrome. And actually on day 3 after ruling out, came to the nuclear lab and had a stress test. And this is just the polar plots to show here that her anterior wall, and here is perfusion with exercise, perfusion at rest, and you could see here this entire green area jeopardized myocardium doing stress testing, walking on the treadmill she was up to like 5 minutes of exercise, and you see the area in white showing that area of jeopardized myocardium totally reversible at rest. So she went on to the cath lab and had a tight, very tight stenosis of the proximal LAD, as you see here, and went on to have a stent placement and was sent home with the classic guideline-mediated therapy of aspirin, clopidogrel, dual platelet inhibitors, statin ACE inhibitor, and metformin. We fast forward as she tells the story that she comes back 3 months later, post-stent placement, now with an acute anterior wall ST elevation, myocardial infarction, heart attack, secondary to stent thrombosis. You see here all of her medications. She sort of admitted that she was taking her medications, and we couldn't figure out what went wrong. So hold that thought. We will come back to her in a minute. So as we think of the why for healthcare delivery design and why we need to include the determinants of health, let's look at some of the evidence. What do we know about the social determinants of health and their impact on healthcare? In the infographic, you see that social determinants of health account for about 40% of health outcomes. If you were to look at this infographic from the Kaiser Family Foundation, that I think clearly illustrates that health disparities are driven by social and economic inequities, you can see here things like economic stability, non-biological, not neighborhood and where we live, because we write prescriptions, especially for patients with heart disease, physical exercise. You need to get 30 minutes a day, definitely, to prevent primary and secondary prevention, education, food insecurity, community safety. All of these factors impact health outcomes. And you look at what the factors attributed to health systems, and you could see health coverage, it only accounts for 20%. Interestingly enough, some of the structural factors of our society, such as racism, structural racism, and discrimination, definitely goes across all of the social determinants of health. So clearly, as we redesign healthcare, we have to factor these factors in and really co-create solutions and treatment plans that account for these social determinants of health. As we think of barriers to adherence to medication and treatment strategies, and hold the thought of that patient who had at her 4th ER visit, she got life-saving strategies, but comes back in 3 months later with stent thrombosis, something that is sort of not heard of, especially with drug-eluting stents. What could have gone wrong? And we look at these data here, and this infographic published from the Mayo Clinic proceedings in 2011, even before COVID, in investigators thinking of how we empower patients to be partners in their care. We see they highlight here, the investigators highlight 3 areas that we need to focus on. That barriers to adherence to medication and treatment strategies could be patient-related. And so you see some of the factors: a patient's low health literacy. What is their preferred language? Is it a language other than English? And note that it's not whether you understand English, but what is the language you're speaking most times of the day, many hours of the day? Health beliefs, cultural beliefs. Are we giving medications that have side effects? Frequent dosing, lack of choices, cost of medications are factors we need to consider. Additionally, as we think of some factors that are medical team related, are we giving up complex drug regimen? What are the communication barriers? Are we using the principles of health literacy, of plain language? So ineffective communication is truly one of the factors. And then, of course, we're all human and unconscious bias. Do we make assumptions of our patients and customize based on our own unconscious biases how we communicate with patients, what treatment strategies we offer them? And then, of course, there are factors that are health systems related: office visit limitations, lack of diversity in clinical research, the one-size approach that we apply in terms of medications. And these are all factors that can affect how our patients adhere to a treatment plan. And so we go back to our patient, NR, and we see that language was really a problem. So she comes back in now, she's 50, she's following up for our stent statement, and now we recognize she's completely pain-free. You look at her medical history: blood pressure is better controlled, hemoglobin A1C is much better, LDL cholesterol still needs some tweaking, but much better. And when we figured out that her preferred language, which we asked on that visit several months before, how does she communicate? One of our brilliant team members started speaking to her in Spanish and recognized that she had stopped her aspirin. She took her clopidogrel for 2 weeks. A neighbor had told her that her husband had a stroke taking aspirin, so she stopped her dual platelet therapy, hence leading to stent thrombosis. And once we were able to communicate with her in Spanish, we really were able to customize a treatment plan, because we found out that yes, she understood English, but she spent 10 to 12 hours a day speaking in Spanish, and that was her preferred language. So language and how the preferred language is really important for co-creating a treatment plan. So you think of the social determinants of health and the summary, and you look at that, and we see that disparities, which are often viewed through the lens of race and ethnicity, really should be viewed through across a broad range of dimensions, and its socioeconomic status, age discrimination, geography, language, disability status, citizen status, sexual identification and orientation. These are all factors that need to be incorporated into co-creating a treatment plan that will work, meeting our patients where they are. We move on to look now at what is the data? What are the data to support healthcare delivery disparities? And looking at published data, and this is a growing body of evidence, and these data from the HRRQ published in 2014 highlight that there are race-based healthcare disparities. We see here that patients with early non-small cell lung cancer, if you are a Black patient versus a white patient, definitely this discrimination and disparities in who receive care. And the data highlight 64% of Black patients receive curative surgery compared to 76.7% of white patients. In terms of diabetes management, we know that diabetes is a potent risk factor for heart disease, and that very often diabetes and elevated cholesterol go together. We see that 52% of Black men were given a low density lipoprotein cholesterol test to look for that, compared to 66%. And then the data on end-stage renal disease and who makes it to the transplant list definitely highlight that Black men are discriminated against, with 35% of Black men placed on the waiting list for renal transplantation versus 60.6% of white men. Truly unequal treatment. And then you look at timeliness of care and delay in diagnosis. The data, again, from the HRQ show that 40%, and this is where language comes in, 14.5% increase in emergency department wait times experienced by Hispanic patients compared to white patients, and again, delays in surgery based on race. We look at the impact and the burden of chronic diseases, and you look here at this infographic that highlights that when we think of cardiovascular disease, that African-Americans, Black African-Americans, highest burden, 50% of our African-American populations with cardiovascular disease. You look at risk factors of hypertension, 33%. And then you look at diabetes, again, high proportion in Hispanic men and women. And of course, cancer, again, higher proportion in underrepresented groups. We look at what has made the news significantly, and we look at the data when it concerns Black maternal mortality, and these data highlight here, and you can see maternal mortality rate per 100,000 births by race and ethnicity, looking at the period from 2018 to 2020, and you look at mortality rates for Black women in green, and from 2018 to 2020, you see 3 times the death rate from complications from pregnancy in Black women compared to all other racial and ethnic groups. And these data and this case was, this sort of urgent call was highlighted at the Sundance Film Festival with the movie Aftershock, highlighting the sort of disparity in Black maternal mortality. How does this play out in life? Well, we see that as we look at lifestyle and longevity, that again, Black and African-American men and women, shorter lifespan, 71.6 years compared to 76 years for white Americans, Black and women, Black men and white men and women. So clearly the impact of the healthcare inequities leading to a shortened lifespan. So as we think of healthcare redesign, and this is one of my favorite infographics, we spend a lot of time thinking of what are the components that we need to put into place to get to health equity and elimination of health disparities. And this is an infographic that was from the AAMC, the Association of American Medical Colleges, the plenary address of Dr. Mark Neve, who was the first inaugural Chief Diversity and Inclusion Officer at the AAMC when they were thinking of how we redesign curriculums for the 21st century. And here you see that understanding your community serve, and that is understanding the race, ethnicity, the language, the zip codes, the prevalence of disease, important as the foundational approach. They're all like pieces turning on a wheel. You see that components of diversity and inclusion, patient education, health literacy, language access as its own sort of pillar. Research, diversity in research, governance, do we have voices and lived experience from the community served, how we deliver patient care, healthcare team education and engagement and cultural awareness, all important in terms of getting to health equity. Just a reminder of the definition of health equity, that health equity means reducing and ultimately eliminating disparities, and it's determinants that adversely affect excluded or marginalized groups. This was from Dr. Dipti Chopra, the past president of the American College of Cardiology. And really, it's a human right that allows everyone to achieve the best attainable. And we're looking at it from the cardiovascular lens, but from all healthcare lens, by overcoming all avoidable barriers. And you think of the difference between health disparities versus health inequities. We see health disparities, unjust differences due to race, socioeconomic status, health inequities, really unequal access to education and all of the social determinants of health. So the definition is important as we redesign healthcare. And this powerful visual from the Robert Wood Johnson Foundation, I think says it all. That if we think of achieving health equity, where everyone has a fair and just opportunity to be as healthy as possible, it requires removing the obstacles such as poverty, discrimination, and their consequences, and things like job, food insecurity, lack of access to good jobs, that we really need to address the social determinants of health to truly get to health, to get to equity. And you see here the difference between equality and equity. Yes, we could say everyone has access to healthcare, but if we do not customize care based on the needs of our individual patients or people, we're never going to get to equity. And here you see that everyone has access to a bicycle, but if you're in a wheelchair, you get the same bicycle. If you're 6'2", you get the same size bicycle. If you're a child, you get the same size bicycle. And clearly that will affect the outcome, right? So if you're racing, the person in the wheelchair can't even begin the race. The person who is 6'2" is not going to be able to go as far. But if we get to equity, it's access, but also customized care. And you see customizing the bicycle. And I think this is a perfect visual to think of what we need on the journey to get to equity. I remind us all that even before COVID, in 2011, when Dr. Regina Benjamin was the Surgeon General, that she spearheaded a multi-pronged approach with several agencies and several stakeholders to come up with the first ever US prevention strategy to help us increase the number of Americans that are healthy at every stage of life. And I always go back to this, dusting it out of the archives, to show a couple of factors that we need 4 true pillars. We need a focused approach on healthy and safe communities that requires partnerships. We need clinical and community preventive services, but we also need a focused approach on empowered people, because when people are empowered, they have knowledge, resources, and are motivated to make healthy choices, regardless of where they're living. And they can take an active role in improving their health. And we need a focused approach on the elimination of health disparities. As we showed before, and the evidence is that health outcomes vary based on race, ethnicity, socioeconomic factors. And that if we have an intentional and focused approach, that health disparities are not intractable and can be reduced with an intentional approach. So where are we as we redesign healthcare, and what are some of the models out there for this redesign. I shared with you the Institute of Medicine, their 6 pillars, but I think as COVID was a catalyst for change and shone the light on unmask the health inequities, as Dr. Dodick highlighted in his opening remarks, I point you to, and Dr. Dodick, and this is an article I shared with you from Dr. Robert Califf, or Commissioner of the FDA, who highlighted an infographic that showed that COVID-19 is definitely the catalyst and is to really sort of urge us to prevent the devastating effects of a tsunami, right? That chronic diseases have been sort of going along all along. We, the unsuspecting public, haven't changed our healthcare delivery model. And like a tsunami, if left unchecked, that COVID and this epidemic of chronic disease can have long and far-reaching consequences. Dr. Califf highlighted that we should not put to waste the lessons learned, or that we should put to use the lesson learned from COVID-19, highlighted 3 areas. We have the data. We know that life expectancy has been declining, accelerated by COVID-19. We know that there are several risk factors that can be controlled, like we see increasing obesity, blood pressure, glucose intolerance, especially creeping into our younger populations, and that we know the disparities in health exist based on race, ethnicity, and socioeconomic status. Highlighted the fact public health infrastructure is in great need of reform and redesign. But we can, in the house of medicine and in the community of medicine, at all areas, we can begin to make small changes. And so looking at things such as lifestyle and medication optimization and adherence could definitely make us, move us into improving health outcomes. And I must say kudos to the entire Atria Foundation for giving out 3 grants that will definitely have an impact in the area of making change. So as we think of healthcare redesign, one of my favorite ways of thinking about it is the patient as a partner, moving from patient-centered care to the patient as a partner. And you look at this model that was highlighted in 2015 by Carizian and group in Montreal, showing that in medicine, and when I went to medical school a few decades ago, we had the paternalistic approach. You know, the doctor and the medical team reigned, told you what to do. And that was truly important for the acute care setting. You came in with your acute care MI, we had algorithms, here's what you needed to do. We have transitioned to patient-centered in the past 2 decades. But I always joke and say, if you're in the center, you're like a Thanksgiving turkey. You have a seat at the table, but everyone's picking at you and you do not have a voice. If it's patient as a partner approach, you are part of the healthcare team. And it goes along that healthcare is a team sport, and that what matters to you gets included in co-creating a treatment plan that works for you, that will be sustainable. And so this goes along with the fact that we highlighted that 80% of outcomes, everything other than the medical encounter. So I'd love to share with you a quick 4-minute vignette from one of the documentaries that we made. In 2015, we partnered with David Grubin of Grubin Productions to produce the PBS documentary, RX, The Quiet Revolution. And this was at a time that we were all thinking, how could we catapult a movement to change healthcare delivery? And so storytelling, and I became a storyteller inspired by one of my patients who, after her normal stress test, she was a documentarian, said, we have got to tell stories to empower people to understand they need to be partners in their health. So we set out to 4 parts of the United States to make RX the Quiet Revolution. And this is where people and communities with limited access to healthcare were taking healthcare into their own hands and truly empowering people to be active participants in healthcare redesign. One of the areas we went to, and David Grubin and the team went, I did not make it to Alaska, was to look at the Nuka health system in South Central Alaska. And here is a story from this gentleman who you can see here, 45-year-old, 10-year history of uncontrolled diabetes, blood pressure you can see elevated, definitely weight challenge with a weight circumference of 38, lived in rural Alaska, nearest clinic was over 50 miles away, high school diploma. And I want you to hear his story to really understand the impact of the social determinants of health. So here we go.
When my mom was 8 years old, she boarded an airplane and she left our community for the first time in her life, and she went to a boarding school along with all the other children. And while she was at boarding school, she was told never to speak a Chupik word, so she had to only speak in English. I asked her, what would happen to you if you did speak a Chupik word? And she said, well, all the children who spoke Yupik and Chupik had duct tape placed over their mouth, and they were lined up in the classroom as an example to the other children not to speak Chupik. And I always looked at it as something all the children went through until I heard an elder in Bethel tell me about the grief that the adults experienced because the village no longer had children in it. All the children were gone. And this elder told me that the whole village fell silent. And the trauma of that, I think, is the beginning of understanding where the domestic violence and sexual abuse comes from.
Today, the amount of violence among Alaska Native people is staggering. The physical and sexual assault, neglect, and mental abuse of Native Alaskan children is more than twice what it is in the rest of the country. And more than twice as many Native Alaskan women are victims of rape than women in other parts of America.
And so we're going after all those who have been harmed and those who are doing the harming. We're not victims, we're not survivors, but we definitely are people who have been harmed. And we have harmed. And so we have been addressing that all and believe it's the root causes of much that has happened in Alaska.
They stripped us of our culture, and that trauma was instilled in us. When I was abused, I was told not to talk about it. That's just the way it was. And so we kept silent. And one of the lies we learned as men, and it's every culture that says this, men don't cry. Men don't ask for help. Well, those are lies. Men do cry. Why do we have tears? Trauma in a person's life eats you up inside when you keep that story bottled in. I was holding in all that anger, all that hate, all that resentment spiritually, and it was eating me away. I mean, I've got high blood pressure. I've had become pre-diabetic. Just look at the rate that our people are committing suicide and the domestic violence that's in the communities. We have to talk about it.
To all who suffered at the hands of another, come out from the bitterness, come out from the shame.
The women dance a dance called Rise Up Mighty Warrior, calling out Alaska Native people to break their silence.
Turn to those with love who have only brought you pain. So rise up, mighty warrior, rise up.
We hold 5-day intensive trainings where people share their story for the first time. 8,000 people have gone through our program.
As an adult, I learned to talk about my story. When your spirit hangs on to the lie that I can't amount to anything, I will not succeed, I'm no good, I can't do anything right. Those that were told to you, your spirit grabs onto that, your heart grabs onto that, and you hold on to it and you believe it and you walk it out in life. I carried that. And so when I carried that in my spirit, I gave it to my children. But our spirit is supposed to be free and to be full of love and joy and compassion and be able to help our community to grow into the next generation.
The lies we believe from our past were nothing but a cruel deception.
So it's all of us walking through trauma together and walking together in wellness. All of us. Health and wellness.
Take from us what is right.
We all need to grasp our culture, for those of us who might have lost some of it, to be proud of who we are and not be afraid to say we're Alaska Native.
So rise up, mighty warrior, rise up.
So I think that, you know, Rick's story clearly highlighted the impact of social determinants of health and just some of the limitations of trauma and the impact of trauma. And this is a whole new area of research. And I share with you these data coming out from the group of at Harvard, where Dr. David Williams has been spearheading research in terms of everyday discrimination and the biological impact, as well as data from the Jackson Heart Study, the African-American Jackson Heart Study, showing that, and this is data from Dr. Williams's everyday discrimination scale, an instrument that can be used, checked out and looking at the biological impact. You can see here that people who felt they were treated with less courtesy, received poorer services, less respect, who felt like they were insulted, threatened, and harassed, all trauma. You can see that when he looked at the data in terms of looking at the markers of inflammation, as well as cardiovascular disease onset, that C-reactive protein, a marker of inflammation, definitely increased. Diastolic blood pressure was increased. We know from data from CT scans and the Jackson Heart Study that coronary artery calcium was increased, and these longitudinal studies, hypertension, and it all correlates with stressful situations leading to elevated and chronic exposure to cortisol, which we know damages the endothelium, and elevated norepinephrine levels. Again, evolving data, and these data published earlier this year by Powell Wilson and colleagues in Circulation Research, highlighting, and this is an area of active research, and this infographic is a little bit busy, but I think if you look at it, you could see social determinants of health, as we highlighted before, economic instability, food instability, and when you look at the chronic psychosocial and environmental stressors, financial insecurity, neighborhood violence, all of these are a pathway to chronic inflammation, definitely, and telomere shortening, so having an effect on our sort of DNA. And you can see, fast forward to how it leads to the development and progression of cardiovascular disease, hypertension, diabetes, atherosclerotic plaque deposition that can lead to a heart attack. So an evolving body of evidence to support the impact of chronic stress and social determinants of health leading to increased cardiovascular risk. I bring you back to this sort of infographic, really, that as we redesign healthcare, that we have got to address the patient factors on the healthcare provider, and hence the sort of interest in terms of understanding and learning to mitigate bias, which is part of the human condition. We all have biases, but learning how to mitigate bias is definitely important, and how we redesign health systems to eliminate or address or destroy barriers that constitute structural, systemic and structural racism. So as we move on to think of cardiovascular care, just sharing with you some of the evidence of why we need an expanded model. Cardiovascular care and cardiovascular disease, still the leading cause of death of men and women in the United States. even in the era of COVID-19, data from the American Heart Association supports this. And when we look at the progress made, because we have made significant progress in cardiovascular disease with stents, with statins, with guideline-mediated therapy and controlling for risk factors, here you see data these data were published last year, showing the age-adjusted mortality for a 10-year period, from the period 2008 to 2018 by race and ethnicity. And what you see here is across all races and ethnicities, we have made an improvement. But what is striking is that the impact, and you see in 2008 is the death rate in gray, 2018 in Black. So you look at the slope of the curve for non-Hispanic Black, non-Hispanic whites, all races, Asian Americans, and you see definitely progress however, you look at the rate of progress and you look at the decline in mortality over that 10-year period, and you see that Black adults are 32% more likely to die from cardiovascular disease. Again, reflective of the increased burden in Black African Americans as it relates to cardiovascular disease. And probably as we move further, and this is sort of a busy slide, but I highlight this here to show you that in a recently published study, so young Black adults, these data coming out from Yale, where they looked at close to 2,800 young adults coming in with a diagnosis of acute myocardial infarction. 48 years was the average, 67% women, 18% Black. And when we looked at the delivery of care, of guideline-mediated care, we see that for young women, in terms of guideline-mediated therapy, diagnostic strategies, that it was definitely a race-based sort of inequities, right? And that Black individuals with acute myocardial infarction receive lower in-hospital quality care compared to white young individuals. And they had a lower quality of care, especially if their socioeconomic status was lower. You put this in terms of a clinical perspective, and that, Black individuals had lower quality of care, unemployed, highlighting the intersection of race and social determinants of health, and a call to action for us to truly implement, to eliminate the biases and implement guideline-mediated therapy across the spectrum, because we know these are therapies that work. So clearly, and these data from 2021 showing disparities in healthcare delivery as well. You look at the impact of this, and this is an older study from 2016 showing published in Circulation, the Journal for the American Heart Association, a tale of two patients. And I think this clearly highlights that patient 1 and patient 2, born at the same time, same year, both with cardiovascular disease, and to show the impact of the social determinants of health. Patient 1, highly educated with access to care, health literacy. And this is a theoretical framework that was built based on a multitude of data aggregation, trust in doctors, and it highlights trusting and co-creating a treatment plan, healthcare, sticking to his healthcare treatment. That patient lives to be 76.7, right? Same disease, same cardiovascular disease. The patient number 2, who works a couple of jobs, is obese, lives in a neighborhood with where there's food insecurity, life stress, that rarely, and sort of getting fragmented care, disparate care, not trusting doctors, that there's a 4.4-year gap. And we see these data play out in everyday life in recently published statistics. So as we go, what's the roadmap to expanding cardiovascular healthcare delivery? And I think Dr. Michelle Albert, the current president of the American Heart Association, clearly outlined what needed to be done. She did an amazing job in her presidential address of the AHA that happened in November in Chicago. But this is from excerpts from her ACC, American College of Cardiology lecture that she gave a keynote in 2021. that she highlighted 7 pillars or 7 factors for us to centering equity in cardiovascular care and calling on us all to understand the determinants of health inequities. So being aware, understanding what are the factors, doing the science to bring that into the treatment plan. We need to work collectively to improve access to cardiovascular care. And I think in the era of telemedicine, we could definitely work to improve that, expand our reach, that we needed to reform cardiovascular care teams that she highlighted. Cardiovascular care or healthcare is a team sport. The patient is part of that team. We should enfold social determinants into cardiovascular care, and that there's an obligation that all hands on deck, it takes a village, that cardiovascular professional societies are core influencers. Many groups and healthcare communities and community-based organizations need to be involved, and it fosters partnerships, healthcare workforce diversification, and a clear and intentional approach to dismantling structural racism with the 7 pillars she highlighted. If we were to take a quick look at 3 of these pillars, here is her roadmap for reforming medical teams. The patient as part of the healthcare team, although the patient is pictured in the center, should be part of the healthcare team, but it's really an interdisciplinary and interprofessional approach to healthcare delivery that we need to implement improvement initiatives. It's a partnership with grant agencies and researchers, and really education to really reflect the disparities and the social determinants of health. Social determinants of health have made it into the guidelines, and this is an excerpt from the 2019 American College of Cardiology and American Heart Association guidelines, primary prevention guidelines. And you see that in terms of cardiovascular risk, that psychosocial stresses should be assessed, that in terms of diet, food insecurity should be included. And this is from Life Simple 7, which is now Life Simple 8, because sleep has been included, the pillars in green, that we need to assess health literacy as part of it. So clearly, social determinants of health coming into the guidelines. And in terms of cardiovascular professional societies as core influencers, both the American Heart Association and the American College of Cardiology are definitely leading the way here. The American Heart Association has adopted health equity as one of its core foundational approaches, and the impact goals that every person deserves the opportunity for full healthy life. And as a health equity champion, that American Heart Association will advance cardiovascular health for all, including identifying and removing barriers to healthcare access and quality. And some of these efforts spearheaded by Dr. Cheryl Pegas, part of the Atria family, really, and Dr. Mitch Elkin, really in embracing and embedding the tenets of health equity into the American Heart Association's core foundation and seeing it as instrumental to achieving its mission. And the American College of Cardiology has definitely included health equity resources for its membership. There's a diversity and inclusion committee, as well as a health equity task force, and working collectively with the AHA in terms of changing guidelines. So definitely moving the boulder or pushing the rock up the mountain in the journey to health equity. Finally, just sharing with you a little bit of Northwell's approach and some of the work I've had the privilege and honor of leading. We had sort of the mandate at Northwell Health, which is 23 hospitals, population area of 8,080,000 employees, and about probably, I think we're close to over 1,000 practices. We were forming a new medical school. You see the footprint there, mainly in Long Island, as well as Northern Westchester, Manhattan, and Staten Island. And we were forming a new medical school with Hofstra, the Zucker School of Medicine, a new nursing school. And in terms of training physicians, nurses for the future, coming up with a plan that truly would incorporate the tenets of 21st century healthcare and looking at the epidemic of chronic diseases. The why for doing this, we looked at the population served. You see a truly multi-ethnic population. And if you were to take language as a surrogate, as part of the diaspora wheel, preferred language or language spoken at home, we serve a population where close to 50% had a preferred language other than English. We did the AMA survey. We started with an inventory and data from the American Medical Association survey and found that language services was indeed in dire need of a formalized plan, because benchmarked against the national norms, we did not have a centralized or even a national plan, a standardized plan to focus on language access. And that was a huge area for us in building out our strategy. This is just a snapshot of foundation, leadership commitment with several committees, a focus on ongoing culturally and health literate and linguistically appropriate education for all aspects of the workforce, customized as to the why we needed to do this. Language access had its own pillar because of the population served, and coming up with making sure that our languages or vital documents were in several languages, customized to the needs of the individual site. Community partnership, which definitely sprung to life and became its own entity with COVID, and we now have an Office of Community and Population Health. Workforce, where we empowered our workforce to help us change culture and be active participants, supply diversity, and of course, a focused approach on gender disparities in women's health, led by Dr. Stacey Rosen of the Katz Institute for Women's Health. So we have seen some progress when we look at our Press Ganey scores as to what our patients think about us and our communities think about us in terms of our employees as it relates to customized care to include the tenets of diversity, inclusion, and health equity. And this is just one example of sort of our leadership commitment, where we report into the Board of Trustees, the governance model, we have an executive council, and you see all of the different committees and councils, and clearly a focus for us as we move on to looking at identifying healthcare delivery disparities is really activating our physician council and diversities and moving towards having a formalized council or task force in each of our departments. So we have champion groups. Internal medicine has a group of a multidisciplinary group reporting directly to the chair on identifying healthcare disparities in all areas: pediatrics, emergency medicine, psychiatry, urology, radiology, and cardiology. And our hope is to have a group in every single area. When we looked at some of the performance improvement done by the emergency medicine group, here is an example of a pilot that was done at one of our sites that serves a very diverse population. We have built a dashboard so we could identify where our patients are coming from by race, ethnicity, language, gender, preferred language, top ICD codes. And you can see that when we looked at our time to triage for the same ICD code, for people who had a language other than English, that we had a delay in diagnosis and a delay in treat and release by over 30 minutes was the average time. Some languages up to like 45 minutes. And with a concerted and intentional approach to include video remote interpretation and staff training, we were able, after 3 months, to decrease the length of stay and triage by 50%. So this is one example of why a focus on language and effective communication was able to improve and enhance or delay in diagnosis and enhance treatment outcomes. This is just sort of a roadmap of where we're going. We started in 2010 with a formalized approach. We had an office, diversity, inclusion, health literacy. We evolved to include health equity, taking the American Hospital Association national commitment to equity of care. We evolved to the Center of Equity of Care. And 2022, and as we look at post-COVID and lessons learned from George Floyd, the social injustice, that we are truly linking quality to equity, and hence using our clinical departments and dashboards to solve for healthcare delivery disparities. A lot has been written in terms of framework, and this is one of my favorites from the Manet Health Group, strategies highlighting a focus on education, a focus on research, but in terms of care delivery, dismantling inequities in access, quality, experience, and it's truly the linking equity to quality that we embed health equity metrics into quality improvement, eliminating race-based adjustments that have no medical basis. And we see there's a national movement to do that coming from the nephrology, American Medical Association for Kidney Diseases, bringing an equity lens to care delivery and screening patients for unmet social needs and connecting to community resources. Here is sort of a simple infographic of what are the components if you're getting started on this journey. Again, and this is from the American Association for Family Medicine. They have a social determinants of health toolkit, and it really highlights understanding the patient's communities, learning how social determinants of health work, truly putting in addressing implicit bias as its own standalone focalized approach as part of the whole cultural and linguistic education, and in activating the healthcare team to help in delivering healthcare that is culturally aware and culturally appropriate, but eliminating healthcare disparities, and a focus on improving health literacy. We have modified this to include language access as we live in a country that is truly multilingual, and that understanding that you think and you make decisions based on your preferred language and the language you spend most time doing. What can you do at the bedside? You know, I think seeing our patients as a partner and recognizing the diversity of individuals and really thinking of implementing the models of partnership is important. Asking questions about social needs, using an interpreter, and now we have video remote interpretation where you can see someone to find out what is their preferred language, what language you speak at home. Doing the teach back methods, finding out from your patient before he or she leaves, how would you explain what happened to you or your treatment plan to your loved ones? And this way, you as the healthcare team, member of the healthcare team, gets insight as to whether they understand. You know, the bias is real, we all have it, but checking it, incorporating their social needs, and truly becoming a patient advocate and seeing our patients as partners. And this is a quick sort of 1, 2, 3, 4, 5 at the bedside, you know, seeking your patient's participation, assessing their values and preferences, co-creating a decision and a treatment plan, and really talking about getting a sense of whether your patients truly understand. And I will end by saying, and we have had the honor and privilege of working with the Forbes team to publish a few months ago the book, Reigniting the Human Connection as a Pathway to Diversity, Inclusion, and Health Equity, where we highlight sort of our model that we have tried and true for the past 10 years. It's still a work in evolution. And I think Dr. Richard Levin, who is the president and CEO of the Arnold Gold Foundation, dedicated to humanism in healthcare, wrote a testimonial for us after writing the book. And I think he summarizes it beautifully by saying, the dual pandemics of our times, one biological, COVID-19, and the other cultural, was a catalyst for the urgent need to redesign a model to address inequities and disparities in healthcare. A holistic framework for embedding the tenets of diversity, inclusion, and health equity into our healthcare delivery systems is critical for improving health outcomes for all. And with that, I thank you very much for your attention.
Well, Dr. Mieres, you're an inspiration. Thank you for everything that you do. Thank you for your leadership, and thank you for your support and being a part of the Atria family. And thank you for just an outstanding presentation tonight.